Hello, everyone. Welcome. Great to see you. I think we'll get started. Might as well get some of the logistics out of the way so we can get into the talk as folks continue to join us. So I just want to say hello and welcome, everyone. We're here for Health Humanities Grand Rounds with Professor Christina Gupta. I'm Kim Weed, and I'm a teaching faculty member in the Department of English and Comparative Literature and the co-director of the Hive Lab here at UNC. And I'm just so thrilled that you were able to join us this afternoon. So thank you for being here. And of course, thanks to our sponsors, the Hive Lab and Carolina Seminars, for supporting this series. Before we formally begin with the talk and introductions, I'd like to just go over a few logistics. We do have in our virtual series live captioners. So if you may already have captions appearing on your screen, if you do not, you can take a look at your Zoom menu and click the closed caption button and they should appear, or you can turn them off if you prefer. I also just would ask you to keep yourself muted during the actual talk today. That just helps to minimize distractions and interruptions. But I, of course, welcome and invite you to turn on your camera to give Professor Gupta an audience so she is not speaking into the Zoom void. All of those nods and smiles and inquisitive looks are really helpful feedback for a speaker in the moment. I think for today, we will plan to use a kind of hybrid model for Q&A. So you are welcome to either put your question in the chat or use the raise hand feature. So once we reach the Q&A portion, Irmak and I will keep an eye on any raised hands and call on folks. But you can also, of course, type out a question if you prefer, add it to the chat box. We will keep an eye on those and relay those questions to Professor Gupta once we reach the Q&A portion of our talk. Finally, in terms of logistics, we do record these talks in our series. Ever since we moved to a virtual format in 2020, we've been able to record them and post them to the Hive Lab YouTube channel. So you're welcome to check out this talk and other past talks on that channel. Okay, so with some of the logistics out of the way, I am just so pleased to be able to introduce Professor Christina Gupta. She's an associate professor in the Department of Women's, Gender, and Sexuality Studies at Wake Forest University. And her research interests are in the area of contemporary asexual identities, gender, health, and science. Her talk today will focus on the research that she did for her book, Medical Entanglements: Rethinking Feminist Debates About Healthcare, which was published by Rutgers University Press in 2019. In that book, Professor Gupta begins with an uncomfortable realization that medical intervention can both reinforce social inequality and relieve suffering for individuals. In resisting the impulse to come down for either for or against any specific medical intervention, Professor Gupta argues instead for the preservation of individual choice while simultaneously addressing the broader socio-political structures that perpetuate oppression and injustice. Using 3 case studies of transition-related care, pharmaceutical interventions for sexual dissatisfaction, and surgical weight loss interventions, she makes a case for moving beyond the framework of disease or medical necessity in favor of flourishing, livability, and fulfillment. After reading portions of the book with my health humanities graduate students this week, I can attest that Professor Gupta's work offers an incisive critique of the normalizing force of biomedicine, and that it proposes bold recommendations to remake the system of medical intervention. This work, I think, is especially urgent in the context of delayed and inequitable healthcare that has been heightened by the SARS-CoV-2 pandemic. And Professor Gupta will speak a bit more about that in the context of transition-related care with us today. So please join me in welcoming Professor Gupta to Health Humanities Grand Rounds. Welcome.
Thank you. Thank you so much, Kim, for that very kind introduction. And Thank you for inviting me to speak here. And as I was talking with Kim during earlier, I was checking out the website for, is it the Hive Lab? Is that how you say it? And it looks like you guys are doing some really excellent work connecting the humanities and the health sciences at UNC. And so thank you all for attending, and I look forward to your questions and comments and engaging with you about my work. So I am going to just post in the chat a link to my talk as an access copy, if anyone would find it helpful to follow along that way, although I know there's also captioning. And then I'm going to, did that go through in the chat? Oh, yes, okay. And then I'm going to go ahead and share my screen. I have a PowerPoint, but it's really just so that you don't have to look at my giant head. There's not a lot of content, so I won't take very long in terms of describing the images on the PowerPoint. But let me go ahead and do that. All right, and then, okay. So this talk comes mostly from my book, Medical Entanglements, Rethinking Feminist Debates About Healthcare, which uses intersectional feminist, queer, and crip theory to move beyond for or against approaches to medical intervention. And was already mentioned, I use a series of case studies to argue that because of systemic inequality, most mainstream medical interventions will simultaneously reinforce social inequality, but also can alleviate some individual suffering. So the book demonstrates that there is no way to think ourselves out of this conundrum, as the contradictions are a product of unjust systems. Is the volume okay? Can you hear me all right? Okay, excellent, thank you. So thus, in the book, I argue that feminist activists and theorists should allow individuals to choose whether to use a particular intervention while directing their or our social justice efforts at dismantling systems of oppression and at ensuring that all people, regardless of race, gender, sexuality, class, nation, or ability, have access to the basic resources required to flourish. So in this talk, I'm going to focus on one of the subsidiary kind of arguments of the book related to the frameworks of disease and medical necessity, which was also already mentioned. So I'll use the case study of transition-related care to argue for the importance of moving beyond the frameworks of disease and medical necessity to justify medical interventions. These frameworks have led to a situation whereby a particular kind of suffering must be framed as a disease, whether anyone actually believes it's a disease or not, in order to justify medical intervention, and especially to secure public funding for or medical insurance coverage of a particular medical intervention. And the disease framework simultaneously drives pathologization and reifies as natural the socially constructed distinction between health and illness. By presenting health and illness as natural categories, the framework of disease allows us to avoid acknowledging the reality that what gets defined as health and illness always depends on political and social decision-making. In addition, frameworks of disease and medical necessity almost invariably pathologize some who do not seek medical intervention, while leaving others without the social support or funding for the medical interventions they need to make their lives more livable. So in place of the frameworks of disease and medical necessity, I propose using frameworks such as flourishing, livability, and fulfillment, while recognizing that there's no perfect language or perfect framework. But in this proposed framework, no particular type of mind-body is inherently disordered or inherently healthy. Rather, these frameworks acknowledge that some people may find a particular form of mind-body configuration at a specific time to be in need of alteration, while others may find what looks like a similar form of mind-body configuration to be perfectly congruent with flourishing, depending on the context. So the structure of my talk is as follows. I'm briefly going to describe how the frameworks of disease and medical necessity are defined and how they function more broadly. I'll briefly discuss the case study of transition-related care, and then I'll come back to using the frameworks of livability instead of disease and medical necessity. And then finally, I will briefly attempt to explore using the language of medical necessity during the use of the language of medical necessity during the pandemic, and how that has impacted particularly transition-related care, as well as reproductive justice-related care, and whether the alternative framework of livability would produce different outcomes for marginalized groups and individuals. Okay, and so as I said, these are just decorative images, really more than anything, but this slide just has an image of the Diagnostic and Statistical Manual of Mental Disorders, and then an image of a form to fill out for funding Medicaid or Medicare coverage of a particular intervention justified based on medical necessity. Okay, so the frameworks of disease and medical necessity. There's a large body of literature and philosophy of medicine on the definition of illness categories. So I'm just going to very briefly summarize it. There is still significant debate among scholars over how to define illness and where to draw the line between sickness and health. So there's sometimes considered two kind of schools of thought. So one school of thought is that we should have a naturalistic account of disease. So that, for example, disease is defined as deviation from species typical functioning. However, as you probably can tell right away, and as many critics have pointed out, what's considered species typical functioning can't really be established objectively. And even if it could be, equating what is natural or species typical with what is healthy relies on this kind of problematic value judgment. Another school has argued for a normative account of disease, so saying we recognize that disease is a socially constructed category, and so we should explicitly define these categories based on values. However, in addition to other problems, these accounts tend to, as I mentioned before, pathologize at least some who do not wish to be pathologized, and then leave sort of unpathologized some who might want to benefit from medical intervention. And in terms of determining whether a particular medical intervention will be funded in the current disease or illness model in the United States, in order to access a publicly or privately covered medical intervention, a person must conform to one of a finite list of bodily or mental states deemed pathological or disordered, and this conformation must be verified by a medical professional, so it must be authoritatively diagnosed in most cases. So in other words, for example, a person must have a particular body mass index confirmed by a medical professional in order to obtain medical coverage for bariatric surgery. And in general, health insurance, whether public or private, is supposed to cover those procedures deemed medically necessary by medical professionals. Of course, what is deemed medically necessary changes over time, not just with the development of new understandings of the mind body and new medical interventions, but also with changing social norms. And then, of course, even when medical interventions are deemed medically necessary, they still may be inaccessible for people without any form of health insurance or with low-cost health insurance, and people who cannot afford copays and deductibles. Okay, so moving to the case study of transition-related care, and the image here is a photograph of folks at a rally or protest through the Sylvia Rivera Law Project, demanding transition-related healthcare coverage for low-income New Yorkers. So in the book, I begin with transition-related care as a case study because trans activists and scholars have already spent decades grappling with the complexities and contradictions of medical intervention. And I argue that they have developed theoretical tools for dealing with the complexity of medical intervention that are applicable beyond the specifics of transition-related care. So different forms of medical intervention have played an important role in the lives of some trans people for over a century. Trans activists and scholars argue that for some trans people, medical interventions can make minds and bodies more inhabitable and can even be life-saving. And yet, transition-related medical interventions have never not been problematic. Trans scholars and activists have also long argued that medical professionals have served as normalizing gatekeepers, enforcing antiquated, racialized gender norms on transgender people seeking transition-related medical interventions. Trans scholars and activists have also critiqued the fact that our society in some way compels trans people to undergo medical interventions, whether desired or not, because transitioning medically and surgically can reduce some of the stigma or discrimination faced by trans people and is required for trans people to access a number of rights and services such as ID changes and things like that. So as a result, trans activists and scholars have long been engaged in the project of imagining different, trans-affirming, feminist, queer, crip, anti-racist ways of structuring transition-related care. At the same time, not all trans people need or want to access transition-related medical interventions, yet all are touched directly or indirectly by the stigma that comes from being labeled or associated with illness categories such as gender identity disorder or gender dysphoria. As a result, some trans activists and scholars have called for the complete depathologization of trans lives through, for example, the removal of gender identity disorder or gender dysphoria from the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders. In some cases, this argument has been made in a somewhat ableist way. So rather than attempting to remove stigma against disease or illness, and in particular mental illness, this approach simply seeks to distance oneself from the category of disease or illness. In general, however, many trans activists and scholars have grappled seriously with the question of how to reject the notion that all trans people are disordered or in need of medical intervention without using ableist logic and without undermining the legitimacy of those trans people who do need or want medical interventions. As a result, a number of trans activists and scholars have developed alternative justifications for medical interventions that do not rely on the disease or medical necessity framework. As an example, some trans activists and scholars have used a human rights framework. Relatedly, bioethicist Jamie Lindemann Nelson suggests that transition-related care should be seen as analogous to pregnancy and birth-related care, writing, quote, "Motherhood is a social role that many people deeply want to occupy. Moreover, many of them want to achieve that role in a way that crucially involves their bodies. Medical assistance in the project is often welcome and sometimes needed to avert poor or even tragic outcomes. Yet it is not strictly necessary for becoming a mother. There are analogies here with transgender. While many trans people see medical interventions as essential for social acceptance and personal integrity, others do not," end quote. So without necessarily endorsing any one of these particular justificatory schemes, I believe that this work by trans activists and scholars points us in a productive direction in terms of thinking outside of disease and medical necessity frameworks more generally. Okay, so let's see, to go back to the more general discussion of the framework of disease and medical necessity and alternative frameworks. The image on the slide is a poster that says "Label Jars, Not People" from 1986, the Center on Human Policy at Syracuse University, which is a disability rights center. So in general, the stigma associated with disease, along with the process of medicalizing bodily and mental states that fall outside the norm, but do not necessarily require medical intervention, has led to a complicated political situation. On one hand, individuals, activists, and scholars from pathologized groups who do not want to alter their bodies or minds through medical interventions very understandably argue that they are not, in fact, disordered, and may lobby to eliminate diagnoses that suggest that their way of being in the world is, in some way, necessarily imperfect. In recent history, there have been many examples of people from pathologized groups rejecting the label of pathology, disorder, and/or disability, including, homosexuality. When homosexual rights activists in the 70s fought for the removal of homosexuality from the Diagnostic and Statistical Manual of Mental Disorders. Those members of the deaf community who will not use the label of disability to describe deafness. Some trans activists who seek to eliminate the diagnosis of gender dysphoria. Some asexual activists who argue that asexuality is not a disorder, which I talk about in another chapter of the book. And some fat pride activists who argue that fatness should not be considered a disease, which is also in another chapter of the book. And this argument is in part entirely appropriate. If medical intervention is not needed or desired, why should members of a socially marginalized group receive a medical label? On the other hand, the quest for depathologization can have often unintended negative consequences. For one thing, it can be an essentializing argument. So to assert that one knows oneself to be not sick or not disordered or not disabled suggests that one can know what it means to be sick, disordered, or disabled. In other words, that these social categories have ascertainable borders. In addition, it suggests that the conditions left behind in the realm of pathologization are inherently disordered, when in fact, disability studies scholarship suggests that all pathological conditions are, to some extent, produced by the interaction between body, mind, and environment. And at the same time, the quest for depathologization is often also motivated by a desire to escape the stigma associated with pathology, which, although understandable, does not challenge the stigma itself, leaving it in place for those individuals and groups who remain within pathologized categories. Even if the quest for depathologization is not about escaping stigma, the very intensity with which many activists pursue depathologization can send the message that the problem is not just that a categorization mistake has been made, but that there is something undesirable about the category into which one had been placed. In addition, this move can lead to the marginalization of individuals who belong to the group that some are seeking to depathologize, and who also need or desire medical labels or interventions for other aspects of their mind body. So for example, a person who identifies as asexual and who has an autoimmune condition may feel uncomfortable with the assertion that asexual people are not sick. And in addition, as mentioned before, it can be difficult when some members of a community do not need or desire medical interventions, while other members do need or desire medical interventions. And so clearly this is the case for trans communities, but also for a number of other pathologized categories, such as autism, where some people with autism seek depathologization and demedicalization in favor of a neurodiversity model, whereas others seek specific kinds of medical interventions to address specific symptoms. In these cases, it can prove difficult to depathologize part of the community while leaving medical labels and interventions in place for other members of the community. As we've seen, trans activists and scholars have developed frameworks for thinking about medical interventions that move beyond a disease or medical necessity model. In part inspired by their work, in the book, I advocate for abandoning categorical frameworks of health and illness altogether in favor of the language of fulfillment, livability, and flourishing. And the language of livability and livable lives comes from a variety of places. For me, it comes most directly from Judith Butler's discussion of precarity and livability. So Butler argues that all human lives are precarious, but some lives are made more precarious, and in fact, some lives are not even recognized, and thus, when they are ended, they cannot be grieved. Thus, Butler argues that we must turn our attention to what conditions must be created in order to advance the flourishing of all lives or the livability of all lives. For Butler, livability is certainly about meeting basic needs for food, shelter, and physical safety, for example, but it is also about social recognition or social intelligibility. Butler writes, when we ask what makes a life livable, we are asking about certain normative conditions that must be fulfilled for life to become life. The language of livable lives also comes to me more obliquely from disability studies. As discussed in chapter 2 of the book, the Nazis described disabled lives as lives not worth living. And thus, disability rights activists and scholars have insisted that disabled lives are worth living, they are livable, but can be made more livable through the elimination of ableism and the creation of a world that is designed to accommodate mind-body diversity. So I argue that medical interventions can be justified not based on whether they treat a particular categorical illness, but based on whether they promote livability. So this is a more phenomenological model. And so in this model, certain aspects of our minds or bodies in interaction with the world may be hindering our ability to flourish, and certain medical interventions might improve our ability to flourish. To the extent that two people might share similar forms of bodies or minds, it is entirely possible that the flourishing of one might be promoted by medical intervention, while the flourishing of the other might be harmed by the same medical intervention. This model does not presume the cause or origin of a particular form of embodiment or mindfulness, apart from the assumption that mind bodies are produced through the iterative interaction of biology and society. And it does not presume that medical interventions are the best or the only way to improve our ability to live a fulfilling life. In some cases, altering society may be the better option, or both medical and societal interventions might be pursued simultaneously. So I am not suggesting that this is a perfect model for thinking and talking about medical interventions, or that this should be the one single model, but it is one alternative way of conceptualizing medical interventions that can help to avoid some of the political problems discussed already. At the moment, terms such as livability could allow us to talk about different medical interventions as promoting individual and or communal flourishing without needing to position anyone as lacking, deficient, or diseased in order to justify the use of a medical intervention. And leaving behind the framework of health and illness would also allow us to shift discussions about public funding for and insurance coverage of medical interventions away from doctors and medical researchers. So in this change, rather than relying on doctors and medical researchers to tell us what counts as an illness or as medically necessary, a more representative body of people could decide collectively what interventions should be publicly funded and what might remain as consumer goods. And so discussions about what interventions will promote livability will be as fraught as discussions about what interventions are medically necessary. But at least the altered language makes it clear that these are discussions about scientific and medical facts and values. So now I'm going to turn to thinking about medical necessity and livability in the context of the pandemic. And the image on the slide is just, I think, a lovely graphic created by the Trans Mutual Aid Network of Manchester in the UK that was a local mutual aid organization for trans folks in Manchester. Okay, so the book was published right before the beginning of the pandemic. And so with some trepidation and reluctance to return to work that was produced in what feels like a different era, I have tried to give some thought at various points to whether my arguments in Medical Entanglements hold any explanatory power in the current context. So I think the pandemic has highlighted both the weaknesses and strengths of using the framework of livability to justify medical interventions. And there's a couple of issues, that could be reconceptualized through this framework, such as healthcare rationing and actually vaccine mandates I've been thinking about. But here I'm going to discuss the issue of urgent versus non-urgent medical care, as it directly affected both transition-related care and reproductive justice-related care. So as I'm sure you know, in the spring of 2020, the CDC and other agencies recommended postponing elective and non-essential surgeries and procedures. However, the definition of what counted as urgent and what counted as elective or non-essential was left open to interpretation. And so as of May of 2020, at least 11 states had attempted to exploit the pandemic by banning or restricting abortion access as non-essential healthcare, although most of the bans were blocked. I think they may have only gone into effect for a short time in Texas. Abortions, of course, are extremely time sensitive, as a delay of even a week can significantly change what type of procedure is done, thus increasing risk, or can mean that abortion can no longer be performed at all. In general, the American College of Obstetrics and Gynecology defines abortion as essential medical care, but medical definitions of abortion are regularly superseded by the federal government and state governments. Transition-related care was generally classified as non-essential healthcare, but this actually does make sense within the context because transition-related care is usually, although not always, not quite as time-sensitive as abortion care. In April of 2020, the National Center for Transgender Equity released a blog stating, quote, "We understand that people have fought long and hard to get access to medically necessary gender-affirming surgeries, and that postponing surgeries that have finally been scheduled is a major blow for many people." But go on to state that because hospitals were experiencing or expecting severe shortages of beds and supplies, hospitals were postponing and rescheduling any procedure that wasn't an emergency. And so they write, quote, "We believe that in this situation, hospitals are doing the best job they can and are, for once, not signaling transgender patients out," end quote. There certainly were and still are significant delays in transition-related care due to the pandemic. In one study, over 30% of participants reported an interruption in receiving or a delay in starting gender-affirming hormones, and more than 10% of participants reported having a previously scheduled gender-affirming surgery canceled or postponed. And these delays undoubtedly cause significant distress for the individuals and communities affected. So again, as the National Center for Transgender Equity pointed out, getting these surgeries in particular scheduled in the first place often took years of struggle. And some people were concerned that they would no longer have the same insurance coverage in the future, or might otherwise face new barriers to care, even if they were eventually rescheduled. However, it is also likely, or probably the case, that most delays in transition-related care were due to concerns about COVID transmission, as well as a genuine lack of medical capacity, and not necessarily about the definition of this care as non-essential. As the National Center for Transgender Equity noted, many other what we would consider essential or important surgeries are defined as non-essential, and so in this context, essential was being used to mean emergency in a certain way, rather than important or valuable. So I think this usage of the term itself was a problem. So using the term non-essential or elective for what feels like essential medical care is understandably upsetting and triggering for many people. And so, a number of folks responded to that. And just one example, Amit Paley of the Trevor Project, stated, quote, "One of the critical steps in pushing for better healthcare is recognizing the necessity of the treatment, challenging the medical classification of elective. These are not optional, nice to have procedures and surgeries. They are medically necessary procedures to support trans and non-binary young people," end quote. So as a simple harm reduction step, it would have been much better to use the language of emergency essential care versus emergency essential care rather than using the language of essential versus non-essential in terms of COVID triage. So anyways, the question that I have tried to think through is as follows. Would the cases of abortion and transition-related care during COVID triage have been different if using a framework of livability instead of medical necessity? So not surprisingly, activists in both cases responded by affirming these interventions as categorically medically necessary. So for example, in the case of abortions, academics and activists argued that, quote, as a time-sensitive procedure that directly impacts an individual's well-being, it is critical that abortion services be classified nationally as an essential medical service, end quote. And as we have already seen, similar arguments were made in the case of transition-related care. And so this makes sense to me. It's practical and understandable. In our current system, medical necessity is a powerful justification for access to services. However, as is clear in the case of abortion, medical justification didn't guarantee access. And as I noted already, a definition of transition-related care as medically necessary may not have actually sped that care along very significantly if a lot of the delays were due to a lack of medical capacity. So again, then would seeing abortion and transition-related care as necessary for livability in some cases, but not others, have helped? And in the book, I suggest that for practical purposes, in terms of implementation, we might, through a feminist democratic process, decide that some interventions are always covered by private or public health insurance for convenience sake, while others might need to be decided on case by case, again, through a feminist democratic process that takes into account the particular context of the case. So in theory, I think I could argue that abortion could have been defined as emergency essential care, and transition-related care could have been defined as non-emergency essential care, but individuals for whom transition-related care was actually an emergency could have received some sort of exception based on a consideration of their particular context. So this may have allowed some individuals to receive transition-related care sooner than if it had been defined categorically as non-emergency essential care. Because I can certainly imagine that there are some cases where transition-related care is as time-sensitive as abortion. But the issue is that individualized decision-making takes time and labor power, which may not have been available during the early pandemic, even for a small number of cases. So in this way, the pandemic has highlighted, the limitations of my argument, as indeed moving from categorical necessity for certain interventions to necessity in some cases for all interventions, moving from categorical necessity for some interventions to necessity in some cases for all interventions probably requires more time and more labor. However, I think this case highlights one of the strengths of my argument as well, which is that it can allow us to expand what services might be deemed essential to an individual's flourishing. So rather than limiting ourselves to specific diagnoses and specific treatments defined as medical, we could think more broadly about what society should provide for an individual's life to be livable. And so I found it striking that in the study that I already mentioned, an interruption in gender-affirming care was found to be less associated with increased psychological distress than losing access to LGBTQ and trans-specific supports, such as community centers, support groups, bars and clubs, athletic groups, or in senior centers. And so I'm not taking this one study as anything but suggestive, but it does raise the question, what if LGBTQ trans-specific supports were considered at least on par with transition-related care in terms of what we as a society are obligated to provide? I think being able to ask this type of question is really the value of the argument I make in the book. So I will end there, and I thank you very much for your attention, and I look forward to your comments, questions, and critiques.
Fantastic. Thank you so much, Professor Gupta, for that. All right, folks. So you've got options for Q&A. You've got the chat box if you want to type something up. You can put a note in the chat that you have a question, or you can raise your hand. But I know it takes a moment for folks to be thinking and typing. So I think I'll kick things off and ask you to something that I guess I'll preface this with something that I grapple with my students in a disability studies course is in comparing all these different models of disability or these different frameworks of thinking about it, you kind of necessarily have to prioritize some things and ignore, or at least temporarily bracket off other things. So I feel like that there's like an analogy or similarity here between the different frameworks that you're thinking about and some longstanding conversations in disability studies about, the social model versus the complex embodiment or so on, and figuring out like, well, what are the frameworks that are maybe doing the less harm, maybe is what I'm thinking of, because of the ways that folks in disability studies at least have articulated the harm that the medical model can do. So really, as you were talking, I was thinking about Eli Clare in particular, who I think really nicely demonstrates the ways that pathology or that medicalization of disabled bodies has been problematic and yet essential for his transition-related care. So as I'm talking myself in circles here, I guess what I'm actually asking is the relationship of the work that happened in this book and you're thinking now to disability studies as a field. Is there a conversation or an intervention to be made in the ways that we think about disability in relation to the cases that you've presented?
Yeah, thank you for that question. And I certainly, the book and my thinking are still very much informed by disability studies, and actually Eli Clare's work in particular, and the most recent book, what is it?
Brilliant Imperfection?
Yes, Brilliant Imperfections, thank you. And I think I talk about it in the introduction of my book, that I see it, him as making in some ways a similar argument, albeit in a different sort of register, much more poetic and lovely register than mine. But yeah, so I mean, I think, what the argument that I'm making is very much applies in disability as well, in terms of disability studies as well, in terms of, there's again a recognition with, as you mentioned, with a concept or a framework like complex embodiment, that, the social is important, but the medical also is important. And so my the effort in my book is to try to think through that as a more general thing, that's basically always going to be the case in for everyone in all medical interventions. And then thinking about, well, okay, so then what, how do we then make decisions if that's sort of always going to be the case? And I don't know if that's responding to your question or not. But I think,
it seems like less about taking your argument and applying it to disability studies, but more so that you're kind of expanding out some of what is at stake in these conversations in disability studies to it seems like a broader context.
Yeah, absolutely. And then also I think, maybe trying to work through then even for disability studies, like sort of more practically, then like, what does that actually look like? And do you, I mean, because I think you can still be in a place in disability studies of, well, do we oppose this particular intervention? Or, so I mean, I think that also that kind of that question comes up in disability studies too, of like, well, then how do we respond to a particular intervention? I think my argument that like, well, let's focus our energies on addressing these broader structures is useful in disability studies as well, in terms of, getting kind of outside of that stuckness of this procedure does all of these normalizing things, but these people over here really helps them in certain ways. So I think it works within disability studies as well.
Yeah, it absolutely does. Thank you. Irmak, I know we at least have one question in the chat. Do you want to take it away?
Yeah. So Melina, first, thank you for the talk. And she's interested in hearing, sorry, they're interested in hearing about your discussion of eugenics and biomedicine in your book. If you could talk a little bit about that relationship and how do you, if at all, consider theories of necropolitics in relation to medical interventions?
Yeah, thank you for that question. I appreciate it. So yes, I have to go back and actually reread what I said about eugenics in the book now. I think what I kind of argue is that all medical interventions are eugenic in a certain sense, or not all, but all mainstream medical interventions are eugenic, in that they all are in some ways about bringing mind bodies into line with a socially normative conception of what a mind body should look like. And so they all have that. And it's about, it's usually about, in terms of mainstream medical interventions, the elimination or management of illness and disability. So I think, that for, in terms of mainstream medical interventions, they all have that kind of eugenic aspect to it. And then I think I do talk about sort of the conversation. I talk a little bit about the conversation that people have in bioethics versus old eugenics, which was state-run, versus new eugenics, which is it's supposedly better because individuals are deciding it, but yet the consequences are often the same. So maybe a state isn't forcing people to be sterilized, but if you're terminating a pregnancy because you expect the child to have a disability or something like that, that the consequences might end up being the same on a societal level. I think I'm rambling a little bit. So I think what I'm saying in the book is that, all of that is true, and that's all part of medical interventions. And again, so that contributes to this kind of dual aspect to medical interventions. So therefore, again, you can't sort of think your way out of it. Oh, like maybe these medical interventions don't serve this normalizing function, or don't have a kind of eugenic aspect to them. No, they probably really all do. But yet also, as I said, they can reduce suffering in some cases and be necessary for individuals of ability as well. In terms of necropolitics, I'd be really interested, if I don't know if this is allowed, I'd be interested to hear from you, from was that Mindy who? No, sorry, that wasn't Mindy.
That was Melina.
Melina, yeah, definitely. I'd be interested to hear from Melina about the connections you might see, or disconnections you might see in terms of necropolitics. So part of the book is also arguing that, while medical interventions are normalizing and eugenicists, lots of people also don't have access to them in a way that, is deliberately leads to death. And so again, this just adds this other layer of complexity too. So these medical interventions are eugenic, have these eugenicist aspects to them, but the denial of them is also disproportionately, they're disproportionately denied to populations deemed disposable, right? So yeah, if there's time at the end, I would also love to hear your own thoughts on that, Melina.
And it looks like Chi has their hand raised, so I think I'm going to let them go next.
Hello, can you hear me? Okay. Hi, thank you so much for this talk. I want to say first that it tickled my brain in so many wonderful ways, and I'm looking forward to reading your book. I started noting down my question before your talk ended, so I know that you did end up talking about this to some degree. But I was wondering if you could offer some suggestions for how a framework of livability and flourishing might manifest within our current healthcare system, or do you think that it's something that is contingent upon us scrapping privatized healthcare and starting anew? And on an individual provider level, as a future trans and neurodivergent primary care, hopefully doctor, how can I apply a framework of flourishing and livability in my practice? Thank you.
Thank you. I appreciate that very much. So, I mean, I think obviously it would be easier and better if we scrapped privatized medical insurance and medical care in favor of, well, at the very least, you know, a national health insurance. But I think there are probably ways you can work it into the current system, or that it does exist in small pockets in the current system that maybe you could expand. So I think I talk about in the book of cases, examples from the UK where they have national health insurance, obviously, but where people, you know, can appeal a decision to a board and then it gets considered in a more contextual way. And I think, you know, that happens in the US too. So if there was some way that that could be expanded and that more people and more voices could be brought into like who's reconsidering those cases, right? That is maybe a small way that it could be sort of done in the current system. But I mean, you know, it's still, even if you move to a national insurance system, it doesn't solve all the problems in the sense that, I mean, I think I quote a bioethicist in the book. I think maybe it's the same one I quoted in the talk. But she says, you know, there's almost like a never ending demand for medical care. Like if it was, if there's an infinite demand for medical care, but not an infinite supply. So and then, you know, if a society is devoting all of these resources to medicine, then it's not devoting those resources to other things, right? So you still then have to make decisions about like, what is society going to cover in terms of interventions? So I think, you know, it would be much, much better if we had a national system, but we would still have to do this kind of really complicated sort of decision making. Did that address your question? Oh, and then you asked as a future provider, which is wonderful and amazing. You know, I think it's interesting. I mean, I've read some research on, for example, trans folks who themselves identify as trans, working with trans patients, and how it can be both joyful but also really difficult because sometimes they themselves have this experience of medicine as as a gatekeeper, and then they end up having to kind of serve the same role for other trans people, which can be a very uncomfortable situation. So, but I think, you know, in terms of individual providers, you know, there's a lot of work on narrative medicine that can be, I think, helpful in terms of like, you know, of course that takes time, which you don't always have, right? But getting to know the stories of individual patients so that you can do this kind of more contextual kind of thing with them. But yeah, I think it's hard, right, for any individual provider who's operating in, you know, this existing system. But I'm glad you'll be doing it. Thank you. Oh yeah, the narrative medicine workshop tomorrow. Not that it's perfect, but I think it can be somewhat helpful in terms of actual providers. Yeah.
Okay, and then I think we had Mindy ask a question in the chat. She said, would you mind sharing a bit of history context about the term feminist democratic in relation to decision-making processes?
Yes, thank you for asking that. You know, so I'm not a political scientist or a feminist political theorist. And so there's a whole area of feminist political thought on what is like feminist democratic decision-making look like. And I'm thinking of like Linda Zarelli's work, for example. And so it's not, so I'm kind of like I have to rely on them to sort of think through what that looks like, because it's not my expertise. But what I understand from that literature, I mean, it involves, you know, there's sort of extra attention to historically marginalized voices in a feminist democratic decision-making process. So that's kind of a common theme. There is, which, you know, isn't necessarily the case in like a non-feminist democratic decision-making process, right? And I mean, it usually involves, or often involves, there has to be a place for different folks to share different perspectives, but with the recognition that not all people's voices are heard in the same way or given the same value or weight. So that sort of has to be taken into account. And it's in some ways there's a little bit of hand waving, right? In terms of like, okay, that sounds nice, but what is a feminist democratic system, and what would it actually look like? And so, but I think it's just, I would see it as similar to like feminist definitions of objectivity, that in terms of traditional notions of objectivity relied on sort of ignoring that there were values in science or political positions in science. And feminist objectivity says, okay, we know there are always values in science, rather than trying to eliminate them, let's recognize them and grapple with them. And so for me, I think feminist democratic decision-making is the same thing. Like, we know that democracy is not this wonderful meeting of equals that we would like it to be, in which we are all equal conversation partners with equal voices. So then let's be super reflective about, acknowledge that, and then be super reflective about the inequalities and problems with our process that we're not going to be able to eliminate. I don't know if that's helpful or not, but thank you for the question.
Yeah, I know we have one more question, but I just have to chime in to say, like, this really was just such a generative conversation in our class on Monday, really thinking about, compared to some other folks we've read so far, you were offering some really practical possibilities. And yet it's incredibly difficult to come up with, what would that kind of decision making look like within a system that we're also trying to change. So just have to or not even clarify, but just amplify how generative that was for us to think through. Irmak, go ahead.
Okay, I believe we have a question from Krista. She says, in your book, I really appreciate the way you index the contradictory nature of some of the discourses that circulate around medical interventions. This is perhaps too in the weeds, but I was really interested in hearing you talk more about how you understand the ethics of undecidability, which you reference via Derrida in footnote number 5 in chapter 1.
Oh my goodness, somebody who read the footnotes. This is a good reader. Well done, Krista. No, thank you for that question. So I'm not a Derridian, and it was actually a colleague of mine who, yes, I did work hard on the footnotes, so that is kind of you. A colleague of mine was like, oh, this sounds like Derridian undecidability. And I was like, oh, okay. We talked about it. And that's why it's a footnote and not in the main part of the text, because I didn't feel like I had enough grasp of Derrida as a whole, or that particular concept to incorporate it into the text. But my understanding, and you can correct me if you have a better understanding or a different understanding, was that there's the concept of undecidability is this idea that there's not necessarily a right or a wrong path to take. It is, in fact, there is an ethical indecidability, and that so sometimes you just kind of have to decide, and not based on that this is we can see what is more ethical or what is less ethical. And so that was my understanding of the concept, and why my colleague said, okay, I think this might be similar to what you're talking about. But if you have more thoughts about that, or more insight into Derrida's undecidability, I would love to hear from you about that too.
Well, that could certainly be a text to take up in our graduate student reading group, Literature, Medicine, and Culture. Here I am, I'm plugging everything at the same time. All right, we've got one more minute, but it looks like Chi-Chi just dropped one more question into the chat. Chi-Chi, do you want to voice it, or are you okay with me reading it? Okay, I'll go ahead and read it. Chi-Chi writes, I was wondering if you could talk briefly about your decision to use the term transition-related care when talking about gender-related medical intervention access for trans folks, as opposed to gender-affirming care that we see in a lot of clinical spaces.
Yeah, that's a good question. I don't know that I have a great answer to it. I think I probably had a reason at the time that may now currently be escaping me. I think I just encountered that term, and I liked that, again, not to say like that there's neutral or not neutral, but I liked that that it had at least maybe some of the kind of judgment maybe was absent from that term, because there's a lot of different terms being used, and sort of what terms have been used have changed over time. And like some of the terms that used have like already had a negative value judgment involved. And then we've moved to now these terms that have a more positive value judgment involved, which I think is good. But I guess part of the whole spirit of the book was, trying to use like medical intervention instead of treatment. So this is this is the reason. Whether or not you think it was good in this particular case study is open to debate, but the overall reason was like I wanted to use intervention rather than treatment, because part of my argument was like it has this like like medical interventions, they have like these positive and negative valences to them, including like this normalizing eugenics stuff in addition to like the helpful stuff. So I think I was trying to find a similar term for the case of transition related care, because as many trans scholars and activists have noted, like this care has been delivered in really problematic ways, right? And there have been really negative aspects to this kind of care in the ways that it's been delivered, in terms of like, as I mentioned, people being held to these very antiquated, racialized gender norms in order to access this care. So I think I wanted to kind of go with that theme of let's not use a term that automatically suggests either this is a negative intervention or a positive intervention. But I could see why that there would be pushback in that particular case of not using a more like positively valenced term. So that seems fair to me.
Well, I want to acknowledge that we've already gone a couple of minutes over our official time, and I want to honor everyone's time. And thank you all again for being here. One final thank you to Professor Gupta for a really engaging talk and book. Thanks so much for joining us today.
Thanks very much for having me and for all of your great questions. Appreciate it.